Hi, this is Dr. Jonas Leibowitz, an endocrinologist with 30 years experience, here to talk to you about hemoglobin A1C goals. What should my number be? Hemoglobin A1C is a measure of a 90-day sugar average. It gives the patient and the healthcare providers a gauge of where that sugar has been over the last 90 days and an idea of how to treat and how to diagnose and how to follow these patients. A hemoglobin A1C of 7 correlates to a sugar average of about 150, 6% about 120, 5% about 90. On the higher end of 7, 8% is about 180, 9% is about 210, and 10% is about 240. In general, the accepted goal of A1C is 7%. How did we get to that number? Why 7%? Why 150? And it's kind of interesting. You may not believe this, but in the early days of diabetes care, we actually were not sure what that goal should be. We didn't know how aggressive should the diabetes be managed. Are we helping people? Are we hurting people? And how are we helping them if we try to get their sugar better controlled? So an A1C of 7 correlates to a sugar of about 150. And in the late 1990s, 2 landmark studies involving thousands of patients were done with type 1 diabetics who are dependent on insulin for their whole lives, and type 2 diabetics, who may use pills or insulin. And the goals of the study were to try to achieve a more aggressive control of sugar, with a more intensive control by raising medication doses or adding medications throughout the study, versus a more conventional approach, where you kind of let things fall as they may while trying to control the sugar. And the goals were to get the sugar lower. The A1Cs in these 2 studies hit roughly about 7 in the more aggressively controlled groups. And what was found was that microvascular complications, in other words, the complications that may involve the eyes or the kidneys or the nerves, showed a decrease in levels when the hemoglobin A1C came to these roughly 7 levels. And that was really the first time that we understood that if we can aggressively control sugar, we can probably help patients live a healthier life. And ultimately, that's the goal in diabetes therapy. Healthier life and avoiding complications such as those mentioned above. As well, you're also trying to avoid heart attacks and strokes and other vascular events. Those studies were not as clear-cut towards those types of events, but there's a lot of data that shows that maybe the more aggressive we control the sugar, the lower the patients will have those type of events. And ultimately, really a healthier life. So we came to the conclusion that 7% was a good goal, and the societies and guidelines that we follow for treating diabetic patients set 7% as a goal. Some guidelines said, hey, maybe we should get that goal a little bit lower, maybe 6.5%, or even lower than that. And I think the conclusion of that is getting to a lower number than 7% is if it can be done safely. And safely can vary with many different correlates. Safely can vary, maybe the patient can't afford the medicine, so you can't give them that many medications. Most of the time, though, when we talk about safety, we talk about low sugar results. And the more medicines we may add to a patient's arsenal of treatment, we may cause low sugars, especially if those medicines include insulin or may include a family of pills called the sulfonylureas. And some studies that were done as follow-ups to those early studies that kind of got us to the goal of 7 said that if we tried to get to 6 or 6.5 or lower, we had too many problems in those studies, and people kind of backed off the treatment and said, hey, maybe 7 is a good place to be, and we shouldn't go further. However, as new medicines developed, medications that did not cause low sugars, and they could be used additively, one plus another, to treat the patient, and you can get a lower A1C without having low sugar, then it seemed reasonable to get those results a little bit lower. And we have multiple families of medicines that don't cause hypoglycemia. So now there are people who set goals that are lower than 6.5, lower than 6, and even will say, how about normal? So if an A1C of 5.6 is in the non-diabetic range, and an A1C of 5.7 to 6.4 is the pre-diabetic range, and 6.5 is diabetic, what if I can get that sugar below the diabetic range, below the pre-diabetic range, and into the normal range? Would that help the patient live a longer and healthier life? Well, not a lot of data has been acquired to prove that, because that's a very aggressive goal. But if you think about it from a logical point of view and you said, would I rather have a normal sugar or a sugar that's a little high or moderately high or very high, it's very reasonable to say I'd rather have a normal sugar. And if you think about it from a different point of view, if you can get your sugar lower earlier, you may preserve the ability of your body to produce insulin. You may make that insulin that you are producing work more efficiently, and you may allow other hormonal mediators of sugar and other parts of the body that deal with the storage of sugar, such as the muscles and the liver and fat cells, they may work more efficiently in the processing of sugar, and that may allow a greater control over a longer period of time, allowing your own body's insulin and the medications that you may be using to be more effective over time. So if I had to give you a conclusion of how low that goal should be, I would say as low as you can get safely, and approaching normal would be a very, very reasonable goal. It is reasonable now, though, to just review some other issues which would talk about what if you can't get to goal? Is it reasonable to accept a higher number? These are issues that come up in my practice all the time, where I may say that I think the patient's goal should be 8, or maybe even sometimes between 8 and 9. And sometimes the primary care doctor, the patient's family may think, hey, that's too high. Why are we shooting for a goal that's not perfect? And we have to treat everyone individually. If a person is an insulin user, or an aggressive insulin user, or maybe they live alone, or maybe they're older and have many medical problems, perhaps they have kidney disease, or liver disease, or heart disease, or things that may make them prone to low sugar, may not allow them to treat themselves if they have a low sugar, and the outcome of a low sugar may be more serious than running a high hemoglobin A1C, then it is reasonable to keep the patients in a different place. So these are all things that should be considered. So even though 7 is the overall goal, most of us think if it can be safely accomplished, lower is probably better, but some patients need to be a little bit higher.